Excellent. So the message is now the understanding of these fractures, we have started to know it better than what it used to be. And now the indication is you have depression fracture with a rim failure, you have to fix these fractures. But with your experience, have you seen any issues where you have not fixed posterolateral? Is something you have to answer.
The thing is, most of the time there is a difference between the posteromedial and the posterolateral. You see the anatomy of the knee also, that is one is a dish, the other is a convex, that is concave and convex. That means one side there is a pressure, the other is a shear. Lateral side you don't take the pressure, it is the shear, it slides on that. When it slides, the slide usually happens more onto the mid to anterior. So posterolaterally, even if you have a slight depression, that is not going to create much trouble for you. But the same thing on the medial side would create it. So that was the reason this was not being addressed for so long a time. Because we are not looking into it because it was not creating a problem. When the depression was very high, it started like that means when it is crossing the mid part, or at least it is taking around the posterior 25%, then it started creating a trouble for you. Because it is a convexity which was being challenged. If the convexity 75% is intact and the next 25% is lost, that is not going to come in your contact. So in such a scenario, is it worth to go back and do a second, third approach where you have to address touch your common peroneal nerve and do all the stuff about the dissection is needed. So that was the point of discussion. So in such a scenario where it is less than 25% at the back, still you can get away even if you don't touch it. That means decent reduction from the lateral side and getting a bolt from back or your posterior anterolateral screws going from there. So that was many of the cases that was being done in the previous. So they were not having any trouble. But this can't be accepted on the medial side. That was
we are talking about only
posterior. So in such a scenario, even if that is there, posterolateral, I think you don't have a trouble.
So I can certainly say, so if there is a posteromedial coronal shear fractures, there were troubles when you have not fixed. So most of them they landed up in varus. But that is posterolateral corner, when it is not addressed, have you seen any complication? This is my question.
I was about to answer that question. In the last 14 years, I did not see any of them coming back.
Even I have not seen one.
That I need something doing kind of situation. Yeah. But what happens to these once the fracture heals, once the fracture healing occurs, as Ashok mentioned, do they come back to you at all?
So again, like see, if we had this discussion about posteromedial fractures in 2000, we would have had the same answer. Yes. Okay, we would have said we have never seen problems.
Correct.
Okay, so this is something an evolution kind of a thing. Okay, we look into aspects where we are comfortable. Okay, we never looked about going to the medial side of femur even.
Yeah.
Okay, for how many years? Okay, that is because lateral side is comfortable, medial side is not. Okay, so this 25%, all these are very subjective things to say. Okay, and those kind of things have proven to be false everywhere, posterior mal everywhere. So I think right now, I really do not think we need to have a third approach. Okay, and in fact, all these ones at the back of the knee, you don't need to be putting them on prone. So it just needs an understanding and kind of like planning from our side. So what I'm trying to tell you is we even have this discussion before. How many of this proximal tibial mals are coming in for total?
Totally.
I can tell you it's increasing. We are doing more and more total knees in proximal tibia fractures. Okay, and me and another senior colleague, we are writing our paper on proximal tibia fractures. We have more than 100 cases. I have 47 or something. That person has more than 70 to 100. Okay, so I don't think you can say that these don't create problems.
One specific point is like what Ashok was mentioning before. In sports injuries, when you have an ACL and that posterolateral depression, and that when that has not been addressed, there has been
they fail again.
They fail.
So
when you look at it, it will be a very subtle posterolateral depression in the back, and you think that's something which, like you said, less than 25% doesn't require anything to be done. And then when you ignore that, these things tend to fail. Second thing is, you are seeing actually more shear injuries today than what we were seeing 25-30 years ago because of the tubular accident, the way there is the terminology called e-bike accidents now, because the way they sit and when the injuries happen, there are actually more shear forces going through the knee joint than just a simple varus valgus which we were seeing before. So you are seeing more bad injuries. You are seeing these injuries which are which you're still understanding in terms of evolution. So you will get to, I think posterolateral corner is still dark. We are not looking into it sufficiently.
I think in the near future we will understand.
It's still dark. We are not
Better.
seeing it sufficiently.
I think we shouldn't play God till we go better. Okay, so I think we can fix fractures. Okay, that is what we are trained to do. So I don't think the posterolateral corner is any different. I don't think.
No, I'm just saying that you know how to reduce it, fix it, get it back to its anatomical position, so that you're giving back.
And I can tell you, I'm not adding a dedicated approach just for that. Okay, if you can just combine your approaches, plan, and at the most you will need 2 approaches for any cross.
See, analogy wise, and let's take an
Concern
analogy.
what
Let's
I was
say we said,
putting here was, it is like when you are able to do the reduction from the lateral side, you still need to make another window posteriorly and go back and put a plate there, or it is
So
enough.
that is what I'm saying. So you suppose like you have planned it. Okay. So if you have as per your plan, if you have to go to the back, the lateral exposure can be modified to address both. Okay.
That is there.
Yeah.
But my point was, if you have got the reduction from the lateral window, where you can elevate the depression and pass your screw from the lateral plate or from the lateral side, still you take another window to buttress it from the
So
back.
it depends. So again, what I would go about is see all your articular reduction. That is the articular reduction. Depression happens from the lateral window. That is the anterolateral window. Okay. The posterolateral portion of the approach is predominantly for buttress fixation. Okay. You will rarely do reduction from that approach. Okay. So you look at it. Okay. If you have a very big posterolateral fragment, okay, that needs direct buttress, you probably need to go there, buttress it, reduce that, buttress it, and then do your now your posterolateral column is reduced. Now do your articular reduction and then do your regular anterolateral fixation. If it is purely a depression, okay, at a very insignificant fragment, then this can be done from the front.
That's what I was telling.